Welcome to Conversations in Physical Therapy Research. Throughout this series, we'll be joined by physical therapy researchers and other voices in the PT community to talk about the role of research and how it helps shape the evidence base that supports the profession.
I'm David Rowan, and today I'm thrilled to be speaking with Karin Silbernagel, a leading physical therapist researcher whose work on tendon and ligament injuries has shaped both clinical practice and international guidelines. Karin, thank you so much for joining us today.
Thank you. I'm thrilled to be here to talk about my favorite topics.
Now, Karin, before we kind of get into everything, I want to know a little bit about your background and how you got into physical therapy.
How much time do you have? No, just joking. So I'm born and raised in Sweden. After I went to high school, I was never going to go back to school again. I thought maybe I would be a lawyer, but then you'd be boring in one country. So I really wanted to do sports medicine, physical therapy, activity, like all of us go into being active. So I was at that point, and that was in the 1980s when you didn't have internet, right? So it was books of the US or UK, trying to figure out, really wanted to travel and I wanted to do physical therapy. And United States had also athletic trainers and really good sports medicine programs. So I came to United States just to do physical therapy at Boston University. So I, at the same time, can get my athletic training certificate. So I spent all my free time in the athletic training room, and then I had a bachelor's for physical therapy. So then after I graduated from Boston University, I could stay and work. So I worked in Baltimore in sports medicine. And then, of course, I decided that it was time to go back to Sweden. So I actually went back to Sweden, and then I also started my PhD. So I have my PhD in orthopedics from University of Gothenburg. So we were there for 13 years. And then obviously something wrong with me. And I decided that we should go back to the US again. And I was doing a postdoc in the United States at University of Delaware. And now I'm back at University of Delaware. I've been here. We've been back in the United States for about 16 years.
And as a Baltimore native, I have to ask you, are you an Orioles fan?
So you would assume that I would be a Boston Red Sox, possibly, right? I
Oh,
started
no.
that, but probably a little bit more the Baltimore Orioles. But now I'm close to Philly, so now we have the Phillies too. So I'm
Yeah, true.
non-committal.
All good sports. I know that many professionals tend to kind of lean either towards the clinical practice or research, but you've managed to kind of thrive in both. And was that always your plan? And could you also touch a bit on the direction that your career has kind of shifted?
Yeah, so I think that I don't follow necessarily the traditional path, as you already heard back and forth too. So I really was sports medicine, clinical practice, really wanted to. I've been on the sidelines, I've done all of those things too, and working in really good clinics. My curiosity, and I also knew that eventually maybe I wanted to get my PhD at some capacity. So I think it took me 2 years out of PT school to not do any schooling because you're never going to go back to school. But then I had more questions. There was more things to know, and I actually started with exercise physiology classes at University of Maryland, College Park, to start my master's there, which I then brought with me when I went to Sweden and finished my advanced master's in physical therapy. So it's kind of that pathway of really wanting to do the best with my patients and then trying to figure out what the best is. And there's always more questions that doesn't have very specific answers. And that's, I think, what's kind of driven me to more and more and doing my PhD and working through my PhD. And I'm very lucky today to work at University of Delaware because I'm able to do teaching for DPT students. I have my research lab, but we also have a big clinic. So I still have my hand in the clinic on consultation basis and things too, because I thrive in all three areas. And I think all three areas kind of feed back into getting our patients better.
And I guess, kind of at the broad level, what major questions has your work helped answer, and what questions are still driving your research today?
Yeah, I mean, I think the big question that maybe some of the older physical therapists can sympathize with is that when I went to school, it was a bachelor's at that time, but the anatomy was talking a lot about muscles. We talked about bone, and then the tendon was this kind of rope in between the muscle and the bone that nobody really cared about. So I didn't know more about that structure by itself, and it was considered to be like a inert structure. It didn't do much more than kind of couple the two things. But then when you started in clinical practice, the doctors kept on sending you prescriptions. The patient had tendonitis. They have, rotator cuff tendonitis. They had elbow tendonitis. So then it's like, well, this structure that we never talked about, and apparently, at least I know medical terminology, right? So itis was inflammation. So you started to treating the word tendonitis versus actually having a background of what is this injury? How does tendon heal? How do they recover? So that's really where I started to see, like, I want to know what to do.
Could you also talk a little bit about how the evidence has evolved over time in this space?
Oh, I was hoping you would ask that question. So really, I mean, the main thing that I always talk about, and my students have heard this a lot too, like, so we talked about tendonitis, inflammation, and everybody that learned inflammation, you need to take anti-inflammatory, you need to rest, avoid every pain, all of those things, and we shut people down. But what the evidence starting to happen in the late 1990s, early 1990s too, was that if you took biopsies from these tendon that we call tendonitis, it wasn't really a very acute inflammatory process. So we were treating maybe the wrong word, right? So we started to realize if this is not an acute inflammation, and people were starting to study how does tendon respond and how do they get better and stronger, and that is through mechanical loading. So tendons actually needs to have stress, so you actually strain or you stretch the tendon is critical, not only for recovery from injury, but if you don't stress a tendon, they actually shrivel up and die to the extreme, right? So this mechanical loading that we as physical therapy provide is critical for the health of tendon and recovery of tendon. So we really shifted from rest anti-inflammatory to none. We didn't have to do that, right? So really when I came into the research was, okay, we need to actually exercise them and they need loading, and who is better at that than physical therapists? And the path that I've had then is really to design how do we optimize this rehabilitation for tendon injuries for our patients.
I know that your research hasn't just stayed in the academic circles, it's made a real impact on clinical practice and even shaped international guidelines. Could you share at least one example when your findings directly influence how patients are treated?
Yeah, I mean, I think that, I was just away at a conference this weekend too, and it's just funny that I go back to my PhD research. It still has such an strong influence, but I think it because we was as a pivotal time within our profession. So there's a few things that really have transpired, and it's not just my research with collaborators all over the world, but it's really, we started with Achilles tendinopathy, and I focused on tendon, but Achilles tendon is like the biggest, largest tendon, so it's actually the easiest one to research, kind of. But you have this tendon, and what we started to learn was that we can exercise it and load it. So we started with a randomized clinical trial to see exercise versus just stretch and lower level exercise, and we saw that people that got heavier exercise and eccentric overload was doing better, right? So we started then to see that yes, we have evidence that exercise is better than rest. The next step is like, how do you guide that? And based on my PhD advisor, Roland Tomé, he used pain to guide rehabilitation for patellofemoral pain. So we started that with tendinopathy, and we really started this pain monitoring model that we've used, and that has been, all over the world now that people are using it. And for a lot of other injuries, it's been really beneficial to kind of guide the loading. And it's basically saying like 0 is no pain, 10 is the worst pain. 0 to 2 is very, we call it green. It's very acceptable, right? It's nothing wrong with doing that. It's perfectly fine. And it's okay when you want to load the tendon to actually get remodeling of the tendon. It's okay to go up to a 5 out of 10 in pain. So really kind of understanding that. And I think it helps physical therapists not being worried about causing pain to their patients with their exercises. It also really helps the patient understand, how do I manage this kind of painful injury, but you say I'm going to do exercise, and moving that forward, right? So we have really made some huge strides in that. And then the second part in my PhD then was, okay, so we're telling people tendon injuries can take up to a year to fully recover. And then you have the runners. It's the runners and the golfers are usually the ones that, drive you crazy because they're not going to take any time off. So the question was either always like, okay, you tell me this can take up to a year. You say some pain is fine, but are you telling me I can't run for a year? And then I started looking into that literature, and there's nothing there. And you're asking all these experts, and all the doctors I was working with. And it's general, the answer was, well, it depends. I guess some running is good. And that to me wasn't clinically helpful enough. So if I'm going to be clinically helpful, what kind of study do I do next, right? So my next study then was really to take our exercise program to load the Achilles tendon that we saw doing well. We used the pain monitoring model, and then we randomized people to either have what we call only the rehab, but no running and jumping for the first 6 weeks. And the other group was allowed to do running and jumping activity, but we modified it based on the pain monitoring model, and not only during, but how they felt the next day. And we designed recovery days because we learned that the tendon needs more recovery days of a heavier load. So then we compared these two groups and how they progressed over time. And what we saw was there was no significant difference. Both groups continued to recover as they had done in the other study. But the people that were allowed to do some running and jumping and progressing using the pain monitoring model were not worse off, right? So we can't say they were equal, but they were not worse off. But if you ask the patients, all of a sudden, what does the runner want to do? Yes, if I can do some kind of running and guiding me while I'm doing the rehab, this is going to be critical for me. So that was also one of the pivotal points that really brought the clinical, from me, my clinical questions, to a research study, to the clinical audience. And then I have a lot of runners or any kind of sports come to me. And the reason is like, I'll come to you because you don't tell me to stop. You help me to stay active and how I can move forward, right? So I think that is a really strong impact for health in general too, right?
And I think this kind of brings us to a reoccurring theme in your work, which is the importance of multifactorial considerations in patient care. Could you unpack what that looks like in practice?
Yeah, I think I love these questions, by the way. Thank you. What really brought me, and I think it's important when you're a clinician and I'm a clinician, I don't care what the researchers are doing, and the researchers are doing the things over here, right? I think one thing that we need to start thinking about is that you're doing in research, you're taking a group and then you're looking at the averages, right? So that's really, but nobody is average, right? So this is where we need the clinicians and researchers work together, because you have your study and you say on average you're going to get better, but then in the clinic people are like, well, these people seems to do well, but some of the other ones I have are not doing it. So we have really started, in our research lab too, started to thinking about the tendon health as a multifactorial problem, right? It affects psychosocial aspects because you can't be active. You have fear of movement affects your tendon. You have the pain, you have the structure, you have the symptoms. And then really what we can do with that is putting that in together and starting to see, do we see subgroups of patients that maybe have all diagnosed with Achilles tendinopathy, but maybe they look a little bit different. And if they are a little bit different, how can we treat them differently, right? Starting to look at precision rehabilitation, or really how do I adjust the standard program that you say I should do to my patients? So some of the examples that we've seen is that, for example, we call it activity dominant. We have younger runners. When we look at those with Achilles tendinopathy, they don't have a lot of functional deficits, but they do have symptoms and pain. And a lot of their problem is they're overloading. They might be running too much, right? They don't have enough recovery. So then we focus more about that. But then we also seen that we have these other groups that have higher BMI, possibly prediabetes, high cholesterol. Those are all negative for the tendon too. And they might not be runners. These are sedentary people, right? So still exercise program is beneficial for them, but you might design it a little bit different. Like they might have more functional deficits. You might want to start thinking about other variables and their progression. They're going to improve with the exercise program, but not as quickly, right? So we're starting to see these kind of subgroups and how much is starting to put together. And I think we see that in a lot of other injuries, not just tendon, right? We've thought about it before, like osteoarthritis is a biological disease. And I think we need to thinking about tendon and tendinopathies as more of a biological disease. And the other pathway, I've done a lot on Achilles tendon rupture too, not just these painful tendons too. And what we're starting to see now, like a lot of the work that I'm doing on consultation now is like the increased Achilles tendon ruptures in NFL, NBA, in the Premier League and things too. And I think they're also there when you think the multifactorial is we actually see more of painful tendons in younger. We used to think that younger kids have, Sever's disease or heel pain versus tendon, but we see tendon. But in general, we also know that just like bone, you should go into adulthood with healthy bone, right? You should jump a lot so you have healthy bone. The same thing with tendon, probably, right? So you need to have healthy tendon. You're building them when you're growing, but are we abusing them too much with certain sports, the sports specialization? I mean, all of those things are starting to put together to ensure that we have, well, I can clearly think tendons are the most important thing, but I know there are muscles and bones in the body too. I don't know about brains, but we need to have this all to kind of work and be able to thinking about how do we then keep people healthy through the age span?
I play sports myself. I always make sure to stretch and try to take it easy on my tendons because I watch the NFL. I see tendon injuries all the time, and I feel like there's more and more of these injuries. Just out of curiosity, I mean, I know you kind of gave a pretty nice explanation on that, but why are we seeing more of these tendon injuries in professional sports, in your opinion?
Yeah, I mean, it's multifactorial, right? I do think I have a few theories, and not all of them are we've researched yet. So take my stuff with a grain of salt. I might be wrong with some and right with some, but I think partly is if we are loading more, we are very, very focused on training and loading and things to kind of move things forward, right? So we know that training is important. It's hard with fitting in the recovery in the elite sport, like working on the recovery and the sleep and trying to figure out what are you training. So that's kind of part of the demands. And I think people are coming in maybe to the elite sports now, not being fully built. Now you have people switching colleges and things, and they're all performing. You have less of this, how we're going to build you up and then make you strong and be able to handle it. Like you have to perform every single time. And tendons need recovery. They need a balance. They're not as fast recovery as muscles. And they are affected by these other things too. And really thinking about understanding early symptoms of stiffness and things, which sometimes are being ignored, are really important to think about when you're looking at tendons. And the other part too that I've talked a lot about, both with the NFL and we talking about the NBA and things too, is that we had a lot of hamstrings injuries in the Premier League, right? So now we've gotten much better at strengthening the hamstring injuries. So now we're starting to see more calf and Achilles, right? The forces through your leg is always going to be the same forces, right? So if you're stronger in another part, you're always going to go down to the weaker part as well. So I'm on a mission, and I'm going to tell you to do this too. Like calf strengthening is definitely underutilized. Because if you're thinking about it, running and jumping, your calf is one of the most important muscle to kind of handling the rebounding, and the tendon is what you get stretched out and then recoil, right? But there needs to be a strength, both of the tendon and strength of the muscle to really do that. And I spoke to, football athletic trainers and sports performance coaches and all those things. And they talk, oh, how do we prevent Achilles injuries? And I'm like, well, how many of you do a lot of calf strengthening when you go into the gym? And you have 20% raise their hand, right? So I think it's just we haven't done that, and I think that really needs to start happening, and maybe start happening earlier too. So you are going to do not only stretching, you're going to do heel rises nowadays, one leg at a time. I want you to do 3 sets of 15 on each leg once a day. Promise me to do that?
I'm totally promise you. Absolutely. From here on out, I'm going to do
Perfect.
it. So I know that exercise plays a central role in both prevention and recovery in your work. How do you approach finding the right dose of exercise for each patient?
Yeah, I mean, I think that that's the $1 million question, and I probably will continue doing that for the rest of my career. But we are getting a little bit closer, right? So I think from clinical practice, and really what's exciting, we're working with the clinicians too, is like we need to find things. I can do a lot of things in the lab to try to be very fancy, but a lot of times what happens is back to basics actually relates to all our fancy measures. Every time I try new fancy measures, it's kind of back. So pain on palpation seems to be very well correlated with patient-reported symptoms, structural change, functional deficits, right? So following pain on palpation that we're doing to kind of score it, I'm going to squeeze your tendon. That seems to be a good kind of guidance on how they're progressing. The pain monitoring model works really well for understanding how are you tolerating the program that I'm doing now. So for example, the key with a pain monitoring model is not just how you feel when you're doing it, because a tendon, when it gets warmed up, feels really, really good. So the key is going to be, how do you feel, in the morning the next day? What is your pain level? What's your stiffness level? What's your lowest pain during the day? What's the highest pain? And we kind of score that in, and then we can look at, okay, I have patients coming in with training diaries for 6 weeks, and then I can look at what is your pain, and they document the rehab program, they document all the other activity they do, and then I can start seeing a pattern, and then I can start helping them progressing in the right direction. Like some people, I'm like, I have so much pain every Monday. I'm like, well, because you cut the lawn every Sunday. So maybe half the lawn on Saturday, half the lawn on Sunday, right? So thinking about those kind of things. So when we have runners, a lot of the master runners, what we work with them is they have pain, for example, with running. So they want to do 50 miles a week. So then they try to do, a little bit every day. But that means you don't get a good training stimulus, but you don't get a good recovery either. So when you look at the training, the pain stays the same, nothing happens. So then we rather, okay, it's fine for you to have a really heavy day of that dose and then take 2 or 3 days of recovery. And then when you get back to baseline, we can put a dose in again. So we're working with training diaries, pain monitoring model, pain on palpation are ways you can easily do. Heel rise testing for heel rise endurance. You can do jump tests to kind of follow as well. And we've also done more studies now too to understand, because one of the questions I had, and I've been trying to do this study for many years, like, I don't know which exercise is a little bit more greater load on my Achilles tendon than the next one. And then I partnered with Josh Baxter at UPenn as a biomechanist. And now it took, and was a lot for the Achilles tendon rupture to know which one is less load than walking, or when can I progress. So we published a study with 30 somewhat exercises that we using motion analysis and force plates to estimate the load in the Achilles tendon. So now we have a plan for, if you're not sure, you can look at that. And if the doctor tells you, oh, the patient can walk, but you can't do bilateral heel rises, you can tell them when actually bilateral heel rises is less load on the tendon. So this should be safe to do ahead of time. So we started to do those things too. And now we have newer methods that we can actually measure the tendon a little more directly versus using motion analysis and force plates too, to see if we get the same results. So that's how the research can really help you in the clinic. And you can see in the clinic, we have the graph in front of us down in the clinic. So, okay, you can do this because this is less half than this, right? Oh boy, that was a long answer. Whew.
I got to ask, when you first started out, did you ever imagine having access to technology like these force plates for you to use in your research?
No, I mean, I started having a catalog to find schools in the United States to go to, right? And my next step was to dial in AOL, dialing into the library, so at least you could sit at home finding research articles, but then go down to copy. So that's where we started to. And even though there were equipment, there were technique too, but being able to have it, I'm so lucky with the combination that we have in our research lab. I use a lot of ultrasound imaging, which I love, and I use both clinically and in our research lab. We have motion analysis.
So, kind of just shifting gears, you've spoken before about how research doesn't have to be intimidating. It can be accessible and collaborative. What are some practical ways physical therapists can start engaging with research no matter where they are in their careers?
I mean, I think that there's just so many levels on that too, right? But I think I really want to dispel the myth that research is something here, but my clinical practice is here, and that doesn't match, right? So I think, first of all, that's what we talked about now. What are the clinical things that I can do and standardize? Like, if you want to get your patients better, do the standardized measurements. You can have just a few patient-reported outcomes. I'm going to do pain on palpation for all my Achilles tendon. I'm going to measure calf strength for all of my patients. I'm going to measure quadriceps strength for all my knee patients. Like, having those measurements, because if you don't have measurements, you don't know what to work for. You don't know if they're getting better, and you don't understand why one patient responds better than the other, right? There are a lot of really good virtual conferences, or I much more of an in-person, but going to some of these conferences and actually interact directly with a lot of the researchers, because they're out there. I mean, we love talking to people. If we're talking to people of what we've done, I'm really interested, and I do a lot of consulting in sports team and things too. And I said, I love doing that, but you got to give me something back then too. Like, what is the problem that you're having that you don't see that we're doing, because then we can also do the research to help your clinical practice. And if you want to do more, we always need clinicians to help us with standardized treatment for people that we follow up. And even in your clinic, if you have standard measurements and things too, even if you don't publish it research, you can do understanding your, how good is your clinic at doing things? What are the outcomes in your clinic, right? Are you all doing it the same way?
Totally. And for those PTs who may not see themselves as researchers, how do you explain the value of evidence in delivering high quality care?
I mean, I think that we, PTs in general, we want to do well by our patients. And I think if we don't know what well is by our patients, then and the evidence, I think, will help us do well by our patients. The problem sometimes with some of the evidence is that, yeah, my patient will be happy if I stroke their back for 5 minutes, but it's not going to help them in the long term, right? So if you want to help your patients, and I think the knowing the evidence, and also because if you know the evidence, you can get people to actually do what's going to help them in the long term. Like, it's just telling somebody to exercise rarely works. But if I spend time to say, this is why we're doing it, this is how we're doing it, and this is why, I think the compliance is so much better. And then starting to see those kind of changes. So, without the evidence, you would still be doing, anti-inflammatory and rest for every Achilles tendon patients. And that will be completely counterintuitive for where we are today. When I started ACL reconstruction, they were casted for a long time because the surgeon was protecting the graft, and we had to work. A PT was mainly to get the range of motion back. Now with research, we know that no, you can start moving them right away. So I think the research have really gotten us very far. And I think as us as physical therapists, we need to use the research too to advocate for our profession and advocate to the doctors. And we really, really are good at getting people exercising. And it doesn't mean that they only are exercise or surgery or other intervention. All the other interventions now, PRP, shockwave, surgery, they need us to make sure that they're loading properly and getting the range of motion and moving back to have the best quality of life, right? So with all of those things, evidence, I think that's kind of key to helping us get in the right direction. I don't know if I answered your question, but I got excited.
I love the answer. I think you're spot on with that. So thank you for that. Looking ahead, how can physical therapy programs and mentors help foster curiosity and research engagement amongst DPT students? Any examples from your own teachings?
Yeah, I mean, my philosophy is that if you don't have fun, then it's not worth it. So, and I think I'm always trying to tell my, engage my students in the sense that this is actually fun. It's not some laborious things that you're sitting in your office and just writing. I mean, my son used to say when he was little, he used to say my fun job was when I was in the clinic and my boring job was when I was in the research, because I was mostly on my computer, right? So I think dispelling that the research is only sitting in your computer and writing thing versus clinic is that, but it's actually the combination, right? And I think a lot of our students, while they're coming through our program, we have a lot of research at University of Delaware and they're immersed in it and they hear it. Sometimes they don't realize, but I get a lot of emails from students afterwards. Oh, I just realized that, I read your articles again and I can see what this impact have with the research and what you have done through the career, or what all our other colleagues have done to kind of shape the environment and the treatments that they're having. So, but I think getting them involved and showing them how, not that I'm doing research is boring, how is it directly applicable to your treatment of the patients? I think that's critical to show. And those are the people that we're going to show that, because then they understand that as moving forward. And then we need to help understand, how do you read a research article? Like, how do you get the best out of it? What are the pathways to know how to apply it to your patient? So we have, I think that's us as educator really have to show that. And we take a lot of students in through our research lab too. They're allowed, to rotate and be involved as much as they can. Now they are actually asking they want to meet with a PhD student. Like they want to have a PhD student and ask them questions more informally, or have meetings with certain faculty more informally. And I think that is a good pathway when it's coming from them. Like, we need to have conversation. We need to, connect on a more personal level to know what people are doing and finding it exciting, right? So it's not like I'm sitting on my computer and you're in another area.
Karin, I really appreciate your time today. It has been such a pleasure. And on behalf of the Foundation for Physical Therapy Research, we are just so grateful for everything that you're doing and University of Delaware is doing in supporting our mission. So thank you so much for everything. We really appreciate it.
Well, I got to say too that I really appreciate the foundation. I mean, I had my first grant really at University of Delaware was a grant through the foundation that really put me forward to the path for getting a lot of the large research funding. The support for my PhD students is invaluable, right? Knowing, and it's not only invaluable because they're getting funding; it's invaluable for the process, right? I make everybody apply because when they're submitting their application, they get feedback, they get training, they get other people's support, and they've supported a lot of our students. And then it's been exciting to see our students also are actually doing the Marquette Challenge for the fundraising, which actually has been a lot of fun too. We've done a lot of fun things. They do pie time. They pie our faces, but maybe less fun. But I think that the foundation has really kind of engaged students. They have provided for us faculty and provided for the PhD students and things too. And I think this pathway too, to share what it is we do, I'm really excited about. So I thank you for inviting me.
Awesome. Thank you.